I'd like to introduce Professor Yves Dauvilliers, who's flown in from France. He is Professor of Neurology and Physiology and head of the clinical and research activity of the Sleep Laboratory in the University of Montpellier in France. He's coordinator of the French National Reference Network for Orphan Diseases in narcolepsy, hypersomnia, and KLS. Dr. Dauvilliers is also director of one research group in the Institute of Neuroscience in Montpellier and president of the European Narcolepsy Network, vice president of the French Sleep Medical and Research Society, and past vice president of the EU Restless Leg Syndrome, and member of the Académie Nationale of Medicine in France. Yves is also author or co-author of more than 560 papers published in international and national peer-reviewed journals, several book chapters, and he also edited 3 French books related to sleep medicine. Thank you for joining us, Dr. Dauvilliers.
Thanks for this nice introduction. Oh, the light is very bright. Okay, so I'm very happy to be today with you as every year in this very exciting Congress. So today I want first to update the knowledge about how to best differentiate NT1, NT2 and IH, because there is a lot of overlap and based on the classification, and we have some data to show that we should be able to differentiate the three. If we are basic on ICST3TR, so 2 years ago, there has been some update since 2014 for the TR. And the 3 main disorders we will discuss on are NT1, which quite known pathophysiology of the disease with the loss of orexin neurons. And based on the diagnosis is EDS, excessive time sleepiness, where there is no more than 3 months. You can be able to diagnose patient after weeks. Orexin loss or cataplexy and positive MSLT. MSLT, the meaning of that is below 8 minutes and 2 SORM, and 1 SORM at night may replace one of the SORM during the MSLT. And again, it's item E, which is not very helpful for narcolepsy type 1, but still is symptoms need to not be better explained by insufficient sleep circadian rhythm drug intakes. I'm not sure about that because mostly disturbed nighttime sleep is really part of NT1. For NT2, the pathophysiology is completely unclear, and you need to have excessive daytime sleepiness, no orexin measurement. This is almost never done in routine in NT2, no cataplexy, and positive MSLT. And for that, for this particular condition, item E, so the same of NT1, is really key in terms of you need to exclude insufficient sleep, circadian rhythm, drugs intake, etc. And that makes a lot of sense. And for IH, pathophysiology is very unclear, despite a lot of effort since the last decades. And no cataplexy, positive MSLT, or, and we will detail that a bit, long sleep at night, more than 11 hours. And symptoms need to not be better explained by, again, insufficient sleep circadian rhythm. But that's sometimes complex to exclude, and we will discuss that. And sleep inertia, which is the third symptom, so long sleep at night, sleepiness during the day, and sleep inertia. But sleep inertia is just a supportive criteria. And in the past, 10 years ago, 15 years ago, I have a lot of remark from sleep specialists not really interested in research or details in narcolepsy domain. They say, who care? You can propose pitolisant, you can propose modafinil, methylphenidate. Is there a really key interest to separate the 3 disorders? And more, yes, and especially because they will have different response to orexin 2 receptor agonist. So that will change to go to precision medicine. So based on that, can we speculate that the clinic is explained by the biology? and the symptoms are explained by changes in neurotransmitter. Most of people believe so or want to believe so, but it's not the case. The story is complex, and I will detail some of this sentence. One is cataplexy is not equal to orexin deficiency. HLA-DQB1 or 602 is different than orexin deficiency. Narcolepsy without cataplexy is not equal to narcolepsy with normal orexin. Loss of muscle tone after emotion is not cataplexy. NT2 is not equal to MSLT latency below 8 and at least 2 SFRM. IH is not equal to MSLT less than 8 minutes in NREM. The complaint of prolonged nighttime sleep is not equal to objective prolonged nighttime sleep. And prolonged nighttime sleep and sleep inertia are not specific to IH. But that's very important because there is some belief, and science is not belief. You need to be evidence-based to report something. So I will start very briefly with NT1, which is known. And NT1 is orphan disease with 8 years to be diagnosed, and age at onset is with 2 peaks as we published 25 years ago. And there is a first peak around 15 years old. And there's symptoms, so EDS, cataplexy, hallucination, sleep paralysis, and disturbed nighttime sleep. And you can measure that with the narcolepsy severity scale. It's a self-report questionnaire, easy to complete by the patient. This paper is a review paper we did with Emmanuel Mignot a long time ago, 18 years ago, and I'm happy to spend some time on this slide because that's still correct after almost 15 years. So in narcolepsy type 1, here, so most of the people are orexin loss. Some are in between 110 and 200, and some, as you can see here, are above 200 compared to the control, who are always normal. And IH, we have very few in intermediate range, but nobody below 110. If you go to narcolepsy without cataplexy, it's unclear because some of the subjects are orexin loss. So since 2014, so 7 years after this publication, they should be named as NT1, even if they have no cataplexy at all. And for the subject who are in between, for the cataplexy, you know, with some definition about unilateral, no triggering factor, long cataplexy duration, loss of consciousness, persistence of being lazier after the event. So there is a lot of atypicity for cataplexy. And for those subjects, the orexin is really unpredictable. So it's very important because in the belief of most of the physicians, NT1 equal orexin deficiency. And with the orexin drug right now, it's very important to predict who will be the good responders as function of the dose. And HLA is the same, you know, it's not random. It's highly associated with NT1, but you have more chance to be with HLA-DQB1 or 602 positive if you have without or with atypical cataplexy compared to the control. So the clinical aspect of NT1, NT2, and IH are quite blurry in terms of EDS is present in all of the conditions, but sleep paralysis, sleep hallucination may exist in the 3 conditions with different frequency. Bad sleep at night is supposed to be highly frequent in NT1, but not at all in IH. If you have fragmented nocturnal sleep, it cannot be IH by definition. Sleep inertia is common in IH, but it may be found in NT2, but often not at all in NT1. And long sleep duration is one of the symptoms of IH, but is not mandatory for the diagnosis. And for narcolepsy, it's often refreshing short nap with dream content that contrasts to IH, which is unrefreshing long sleep nap. So based on the clinic, you can predict who can be with NT1, NT2 and IH, but it's just, it's not enough to make the diagnosis. It's just to go to your what you do have in mind. So it's a large spectrum, and sometimes, except for the typical cataplexy, it's hard to really be sure of the diagnosis. So how to best diagnose IH? This is the topic of today. Clinic first, good clinical interview to spend time with the patient to explain what is sleepiness, what is long sleep, what is sleep inertia. And after that, you need to quantify the symptoms with scale, just after the good clinical interview. And after you need to confirm with MSLT, and if you are rich enough, long sleep recording by PhD. I will detail that. So IHSS is a scale we developed many years ago, and it's quite popular right now, using in many randomized controlled trial. It's a 14-item questionnaire, and it's nice questionnaire because it assesses the symptoms of IH, but also the consequences of having IH in daily life. And that's key. And same for narcolepsy severity scale. It's not just how many frequency per week do you have this particular symptom, is the consequences of having in daily life. And after being medicated, it's improved a lot. So this is the clinic. But after, to exclude sleep-deprived condition, to exclude OSAS, to exclude depression, that's really complex, because it's easy to say it's not sleep-deprived. But if your biological need is 10 hours or 12 hours, and you cannot because you need to work, you need to wake up, you need to take care about your family, you are sleep-deprived because you need 12 and you can sleep just 8. So you are sleep-deprived. So what does it mean to be not sleep-deprived? To do so, you need to record the patient in a strict way, standardized condition. Depressive symptom as an exclusion criteria. This is key as well. If you have very severe IH, you can be depressed because your quality of life is very poor. It doesn't mean that the symptoms explain the disorder. So you need to think about this exclusion criteria, but sometimes it's not really exclusion criteria. It may be part of the story. Same for AHI. If AHI is 6, the cutoff is 5. If it's 6, how can you explain MSLT of 2 minutes as an example, or long sleep time of 12 hours? So we need to know the criteria, but they are sometimes strict. So there's a lot of differential diagnosis of IH. Sleep disorder, we discussed that already. Sleep deprived, delayed sleep phase syndrome, OSAS, narcolepsy. There is the medical condition, medical condition, TBI, chronic fatigue syndrome. This is often important differential diagnosis if there is no sleep recording, if it's just based on interview. Psychiatric disorder, mostly mood disorder, as I explained. Sometimes that may explain the symptom, but sometimes is a consequences of having IH being not well treated. And if you take drugs, CNS drugs, benzo as an example, it's hard to make a diagnosis of IH. So this is the clinic, but after you need to confirm the diagnosis with objective assessment. And there is the MSLT or the long sleep recording. And I will detail that. Because in Atlanta, they make this very known paper, Lynn-Marie Trotti, to show that it was done many, many years ago right now and replicated in my lab and in Stanford's lab, that the retest reliability of the MSLT is not good. Everybody uses it in routine, but it's not good. When I say it's not good, it's because the latency changed time to time for a given subject without any drugs, and the number of SFRMS as well. So that's complex to be sure of the diagnosis, because the patient is 1 SFRM, 6 minutes. You redo that again after 6 months, is 2 SFRM, 6 minutes. You change the diagnosis, is the same subject. So it's because our test is not good enough. So you cannot just trust the MSLT. It's just to confirm your clinical assessment of the diagnosis. But I like this paper we did many years ago, published in Sleep, that we cannot remove this MSLT. We can think a little bit differently. If you go to these two scoring of MSLT, for the first one on top, there is 2 SORM and the MSLT below 8 minutes. On the bottom, there is at least 2 SORM and MSLT below 8 minutes. So for the two category is positive MSLT, but it's not the same at all. In terms of the REM latency, it's not just 15 minutes to say SORM. We wanted to look for really as a continuity, a continuum, a continuous sleep latency. Same for sleep latency, not just a cutoff of 8 minutes. The sleep duration in each test, the REM sleep duration in each test, the sequence from wake to REM, if there is N1, N2, or N3 in between, and the value of the first test and the last test, because sometimes the last test, you want to take the train to come back home or your car, and the last test can be an issue if it's different than the other one. So you can put a different eyes and not just 8 minutes and 2 SORM. So we did this work in almost 400 subjects, all with CSF assessment. And we wanted to be without this MSLT 8 minutes 2 SORM, just to see what about the main value within your MSLT that predict the orexin normal or orexin deficiency. And the performances, the best parameters within the MSLT that predict orexin loss or orexin normal is the mean REM sleep duration, above 4.1 minutes, is better to predict orexin deficiency than the value of 8 minutes to SORM. And if you go just to narcolepsy to separate NT1 and NT2, so orexin loss, orexin normal, just within patient with narcolepsy, is the same parameters that pop up. REM sleep duration with different cutoff of 5.7 minutes. So MSLT is really of interest if you not just believe the results of 2 SORM MSLT 8 minutes. So now, this is MSLT. Now, what about the long sleep time? This is the main complaint of subject with IH, long sleep time. But sometimes they cannot because they need to wake up at 7 to work to take care about the kids, and how to really be sure that long sleep is prolonged, the sleep duration is prolonged. Can we just trust the complaint, the self-report? We did this nice study, just came out a few weeks ago in Sleep. What we do in my lab is we do, we'll come back on that after, but the polysomnography, the MSLT, and after the long sleep recording, 1 night, 1 day, 1 night, during 32 hours. And we ask the patient after this bed rest, so he's in the lab with EEG electrodes, and he have no light, no watch, no iPhone, no TV. The objective is to sleep as much as you want, to objectify the long sleep recording. And we ask the patient after the protocol how long sleep he believe he did within the protocol with a grid, you know, and he quantify each time he have in mind he was asleep. So for the first night, during the day, and the second night. And we look for the association between the self-report, perception of the sleep during the bed rest, and the objective assessment with the EEG, because we do have the polysomnography within this protocol. And as you can see here of interest, IH with long sleep time and control estimate correctly their sleep duration, in contrast with patients with suspicion of IH who did the protocol, but for whom we did not confirm the long sleep recording. because in our protocol is 19 hours. We validated that many years ago. So we come at the conclusion that paradoxical hypersomnia exists, as has been reported with insomniac patients. They overestimated the number of awakening at night and the duration of awakening at night in insomnia. And here is the opposite. They overestimated the sleep duration. And that may help to separate also the chronic fatigue syndrome, for whom there is no increased sleep duration. So that's of interest, I think so. So just to prove that the good clinical interview is not enough. Second is actigraphy. Actigraphy, a lot of people, especially in US, do that to quantify sleep-wake duration, but often in many papers, at least 4, they overestimated sleep and underestimated wake. And mostly it's done during one night only. So if you do that just during one night, it's an issue because they sleep well at night. So it's not really helpful. So we did with the same protocol, the bed rest condition, 1 night, 1 day, 1 night. We have the actigraphy in the same time of the polysomnography recording. And if you use, we did that in 200 subjects. And if we use the algorithm developed by the ActiWatch, the COLE, the SADE, this is the algorithm often used to estimate wake and sleep, there is huge overestimation of sleep during the nighttime and the daytime, especially during the daytime. So if you believe what the actigraphy report to you, there is no sleep. It's rest time, there is no movement, but there is no sleep. So it's not perfect to estimate, to quantify the sleep duration. And in the lab, we develop machine learning to propose another algorithm called S2S, so a recurrent neural network, that is better to precisely quantify sleep wake as a function of the actigraphy. So again, actigraphy is not enough. It's overestimated a lot, as you can see here, during the day, the sleep during the day, and also during the second night. So you need to really quantify with EEG the long sleep duration. So this is the protocol, again, we use a lot in my lab since decades, right now, 2 decades. And that is able to differentiate one subject, normal subject, that wake up at 8 a.m. With some very short nap during the day, and a shorter second night because you have short nap during the day. This is 32 hours duration of the protocol. This is a typical very severe IH subject. As you can see, he wake up at 3 p.m., he go to sleep at 11 p.m. the night before, and he wake up spontaneously at 3 p.m. He have a short awakening, and he go back to sleep for 2 cycles. And there is an awakening after he go back to sleep. And this guy slept 26 hours. And of interest, this is really of interest, if this is another guy who wake up at 11 a.m., so based on the first 24 hours, he fulfilled the criteria of IH because he has 14 hours of sleep. But the second night, he cannot sleep at all because he slept too much the previous 24 hours. So if you trust the first 24 hours, he's in the criteria of IH. But if you go to the second night, there is no sleep, almost no sleep. So it's below our cutoff of 19 hours. So how can we put the 2 guys in the same category? One cannot sleep anymore the second night. So if we want to go to the pathophysiology of the disease, we need to be very strict. And for the sleep inertia, we propose, this is the third symptom, so sleepiness, long sleep at night, and sleep inertia, the third one, and we quantify the complaint with IHSS, the questionnaire, and we objectively quantify the complaint with the PVT. We perform that at 7 p.m. after there is the polysomnography, and we do that at 7 a.m. and 7:30 a.m. and also at 11 a.m. So, and as you can see here, very typically, there is an increase in the lapses, number of lapses on the PVT compared to the night before. So that's objective and allowed to really quantify sleep inertia and may be reversible after drug intake. So where we are, based on all of what I tried to explain in the last 20 minutes or 15 minutes, is that NT1 is quite extreme in this continuum of NT1, NT2, and IH when there is cataplexy and loss of orexin. IH is quite extreme in terms of long sleep and sleep inertia. And in between, we have some overlap. So IH and NT2 overlap a bit. And as I told you, with the variable results of MSLT, and all patients are sleepy. And NT1 and NT2 overlap as well when there is infrequent cataplexy, atypical cataplexy, and in between orexin level. And that's very important because that tells you that ICST3-TR is not well enough. We need to do better because right now it's 3 different categories, but it's not correct because there is some overlap that is explained in this graph. And that's also of key interest because just the NT1 will respond to the new drugs, orexin 2 receptor agonist with low dose. And even more complex, sometimes patient may change the category. NT1 not, but NT2 may be NT1 after a while. NT2 may be IH, as I explained to you, with this overlap condition, and IH may be as well NT2. So I will go very fast to the neurobiology of NT1 and on NT2 and IH because it's not known. There is a lot of studies on that. Partial lateral hypothalamus destruction of some orexin neurons in NT2, that's not clear. And in IH, there is tons of studies as well on GABA, histamine, but nothing was really striking so far. So we do not know. It's unclear, unfortunately. I will skip that just to let you know that it's a loss of money and time. If you want to redo that, we assess a lot of metabolite within the CSF of amine, biogenic amine, and their metabolite, and we find no differences between the 3 categories, NT1, NT2, and IH. And the last paper we did a few months ago, published in Sleep, was related to the circadian rhythm hypothesis that may, in some physician, be part of the pathophysiology of IH. We proposed during the same protocol to address the core body temperature measurement with the a capsule, VitalSense, that is able to record temperature. And we did so in 100 subjects, control and IH. And we were able to look for amplitude, the measure, and the Batty phase, and we find no differences as function of the category, the long sleep recording of the sleepiness during the day. So it's not striking in our hands that circadian rhythm explain IH. We didn't do melatonin because it's complex. You need to intervene with the patient for the saliva, and if it's for the blood, it's complex to do that in our protocol because they cannot sleep as they wish, as they want with the IV line. So it's why we use the core body temperature. You know, the most exciting results on genetics for potential translational to IH is the 6-tree. This has been reported by Yanagisawa, Japanese group, to show that this is the only gene so far that is really associated with long sleep in mice, as a mutation in the protein kinase genes, the 6-tree. And we were interested in doing this assessment in 100 patients with IH compared to the control. We perform whole exome sequencing, and we didn't confirm that 6-tree is associated with IH. We find other genes of interest that need to be replicated, like PERS3, but 6-tree, which was our hypothesis, was not associated with. So far, where we are, this is my view on IH. IH is driven by symptoms, EDS, sleep inertia, long sleep time, and other associated symptoms, brain fog, fatigue. What may drive that? Unclear. Neurobiology is unclear. Dysfunction of sleep homeostasis is unclear. Circadian rhythm problem, immune dysfunction, nobody knows so far. Well, there is no animal model. This is more complex than in NT1. The genetic predisposition is unclear. And the treatment, I will go to the treatment right now. So we did this update review in Sleep Medicine Review 2 years ago with Isabelle Arnulf and two US colleagues to read the literature of what has been really done in a proper way with, and there is almost no good data, I may say, in terms of randomized control trial, grade A. The only one probably is the one from the Japanese group, showing that modafinil works slightly, and just 3 weeks of exposure to the drug. So it's really not enough to prove that a drug is long-term effective in terms of evidence-based medicine. The only, I may say, at that time, good randomized control trial to prove that oxybate, it was lower sodium oxybate, works in IH. This is done in a nice randomized withdrawal study period with open label period with drug intake, and after we randomize the subject to continue the oxybate or to be randomized to the placebo. And it works very well, as you can see in IH and IHSS. The prime of this study that allow FDA approval in US, but not at European level, because it's just based on questionnaire. There is no objective assessment. So we decided at that time to do same study using objective assessment. So, and it was just published a few weeks ago. So it's a phase 3 randomized control trial, parallel group in IH for 8 weeks in monocentric, just in Montpellier, in my lab. And the baseline is ESS 16, IHSS 35, and MWT is 19. And we propose this parallel group, these drugs, compared to the placebo. And as you can see on the right, is highly efficient. We were happy to confirm that in just 20 patients per group, it works quite well, highly significant. The APROS at the end of the trial was 8 and 15 for the placebo. And it's highly significant when you adjust to the baseline ESS. Same for IHSS. You decrease 11 points, and the minimal clinical important differences is 4. And the most exciting was MWT. And so with the placebo is 16 minutes at endpoint, 8 weeks. So no change compared to the baseline almost. And there is 15 minutes increase with oxybate compared to the placebo. So it's hugely effective also based on objective assessment. I've been very lucky to obtain this American Academy Sleep Medicine grant with Hypersomnia Foundation. So I'm very proud of that. I obtained that 2 years ago, and we wanted to replicate almost exactly the same study design as I just report to you with oxybate. So randomized, double-blind, placebo-controlled trial to compare efficacy and safety of solriamfetol up to 300 milligrams, so 150 and 300 milligrams compared to the placebo. 28 patients per group, and almost the same inclusion criteria, but IHSS as a primary endpoint and ESS MWT as a secondary endpoint. So we obtained already EMA approval 6 months ago, even more. The contract between the different partners was done, so that's good news. It takes a while, but it's approved right now. The main story that persists, I'm very disappointed and happy, is the placebo. The problem is that the Pharmanovia, who sell the solriamfetol in Europe, accept to give the drugs for free and the placebo, but after it, they cannot do the placebo themselves, so they ask for another company, like named Clinigen to provide the placebo. And it's a nightmare. It takes months for the quality of the control of the placebo. It's very costly to propose the placebo. It costs more than 1/3, around 40% of the grant, just to obtain the placebo, because Pharmanovia at that time say, we will give you the drugs and the placebo, but after a while they say just the drugs, and the placebo was very costly. And the story is very long, and we didn't start. So we will start, but it takes time, and money just for this problem of the placebo. So I'm very disappointed of that. But we will do that because we obtain approval. So, and the last part will be on orexin, just 2-3 minutes. You know that orexin story was very exciting for NT1, but also for NT2. If you increase the dose of 925, TAC 925 IV, it works in NT2 subject less than NT1 with higher dose. And in IH, there's just one study, crossover design, 1 day, just 1 day of exposure to the drugs, but very efficient with the highest dose proposed for NT2. And with 925, you go to 40 minutes of MWT and 10 minutes with the placebo. So huge change, just 1 day. And we were very lucky, happy that we published a few weeks ago the results of 861 oveporexton, the TAC 861 in New England Journal of Medicine, and very efficient drugs for ESS, MWT, WCR, so the weekly rate of cataplexy, and the NSS, which is in right now, the Narcolepsy Severity Scale. So it's highly effective, and now it's go to phase 3 for NT1. But for NT2, they failed because they decided to go to the same dose, because they cannot increase the dose because of the safety issue of hepatotoxicity that has been reported with 994, which is quite close drugs. So unfortunately, they failed. Same dose, NT2. So it's why I say that precision medicine is key for this orexin measurement that may predict who will be good responders to the drugs. But right now there is 3 ongoing trial for orexin receptor 2 agonist, the TAC 360, completely different compounds than the 861. The Synthesa has already one exciting compounds as well, 750, and Alchemers also start a nice phase 2 trial in NT2 and IH. So this is a good hope, I may say, for these compounds and these different compounds with same mechanism of action in orexin normal hypersomnolence disorder, NT2 and IH. So let's see the results in a couple of months. Many thanks for your attention.